Good afternoon and welcome to the Congressional Personalized Medicine Caucus briefing on pharmacogenomics. We are so pleased to have you join us as we discuss pharmacogenomics or PGX and the impact its use can have on improving patient outcomes as well as reducing healthcare costs. To open our session today, I am pleased to welcome Congressional Personalized Medicine Caucus Co-Chair, Congressman Tom Emmer. As a member of the House Republican leadership team and ranking member on the House Committee on Financial Services, Congressman Emmer is an active champion for precision medicine initiatives like pharmacogenomics. We are so happy to have him with us here today. Ladies and gentlemen, Congressman Emmer.
Thank you. Thank you for being here, and thank you for having me here. I hope everybody is surviving all of the Zoom calls. I always thought when we were on the Hill, we were busy enough running from one meeting to the next, and now I feel the same way with Zoom calls, and I just sit in one place. So I'd like to thank the Personalized Medicine Coalition and Invitae, as well as the individuals involved in helping to put together and host this event. And for those of you that don't know me, you just heard, I'm Tom Emmer. I have the privilege of representing Minnesota's 6th Congressional District in Congress, and I'm also, as you were told, the co-chair of the Personalized Medicine Caucus. In that caucus, I work with colleagues on both sides of the aisle to further the understanding and usage of personalized medicine. As most of you know, personalized medicine, or more recently referred to as precision medicine, is an emerging specialty which consists of some of the most cutting-edge innovations in the medical field. From improving patient outcomes through early detection to increasing efficiency and lowering costs, personalized medicine has the potential to save lives and revolutionize treatment. This includes the area of pharmacogenomics. Far too many patients are suffering and even dying because of their prescription medication. Adverse drug reactions kill someone every 2 minutes. This would be the equivalent to a 747 plane crash every single day. These numbers, frankly, are staggering. 99% of the population has a genetic variant that impacts how someone's body responds to a pharmaceutical drug. And more than 91% of our population is unable to process medication in the way that the medication is intended. Every person's unique genetic makeup affects drug efficacy, absorption rate, dosage, and as a result, patient safety. Pharmacogenomics, you never say it, you guys can say it, or PGX, we'll do it that way, can provide this information to the clinician, enabling improved decision-making regarding prescription meds by the physician. Although numerous studies have demonstrated just how critical PGX is to patient care, it's not yet broadly adopted in our healthcare system. Clinicians can be uncertain of how to use PGX, and we don't enlist pharmacists in the effort to determine the best medication to prescribe. By educating and engaging on PGX and how it can be used to maximize patient care, as well as by working with both CMS and the FDA, we can ensure that PGX is readily available to patients in the United States. Broad adoption of PGX testing and clinical decision support tools will help all populations, especially seniors and veterans, who are likely, the most likely to be taking multiple meds. This will also optimize prescriptions for those suffering from things like anxiety or depression. The technology is ready and available now, and we'll continue to explore avenues in which we can ensure that patients have access. We look forward to collaborating with all of you to implement policies that allow all patients to benefit from precision medicine tools like pharmacogenomics. I don't want to take up too much of your time. I know everybody's busy, and I know you are here today to listen to the experts. But I want to thank you again for the opportunity to address you, and I look forward to continuing to work together. If I can ever be of service to anyone on this call, please don't hesitate to reach out. Thanks.
Thank you so much, Congressman Emmer. We're also appreciative that we have Representative Eric Swalwell joining us now. Representative Swalwell is the chair of the Intelligence, Modernization, and Readiness Subcommittee of the House Committee on Intelligence and the co-chair of the Congressional Personalized Medicine Caucus. Thank you for all of your work in championing precision medicine, Congressman Swalwell, and thank you for joining us today.
Thank you, Christine, and thank you to my colleague, Tom, and congratulations, Tom, to your side in the victories you achieved in this last election. I really do look forward to working with you in the new Congress on our shared interest in personalized medicine. And Tom and I are the co-chairs on the House side, and we've got Republican and Democratic co-chairs on the Senate side, and Senators Kyrsten Sinema and Tim Scott. And for me, the excitement around this issue is that, yes, there's a healthcare debate going on across America and in Washington over coverage, and that's important. And it's important that we, sort that out. However, I believe that innovation in what we invest in and what we give patients access to will ultimately bring down the cost, expand access, and make sure that people live longer, healthier lives. And Invitae and the work that you're doing with PGX and the panelists who are joining us today is going to be a big, big part of that. And so Tom and I are committed to working together with our colleagues to really help educate them on the advancements in personalized medicine. And so I wanted to thank Christine and Michael Pollack and Dr. Altman, as well as Dr. Vera for being panelists today. And just to say that our goal on the caucus is to make sure that every human with a genetic variant has access to medications that potentially could be helpful for them. And as we know, too often patients, when they do not know or understand what is ailing them, they go on this diagnostic odyssey, which is costly and frustrating, and of course, not necessarily helps them extend their life and their health. But with genetic testing and PGX, we're able to be more precise and also bring down the cost for patients. Also, we believe that with PGX, we could save up to $528 billion a year. Again, there's a big debate about what type of coverage in Washington, but where I come from, $528 billion per year is a lot of money in savings, and also would, I believe, not only save money, but knowing that misdiagnosis or misprescribing is the fourth leading cause of death in the United States. We also have an opportunity, to allow people to, live longer, healthier lives. So I'm excited about what's ahead. I hope Invitae and the members participating today see us as partners. And while yes, we are a divided country. You look at the vote margins at the presidential level, a Senate where the control hangs in the balance on 2 races in Georgia, and a slim majority for the Democrats in the House. That is very clear. But what motivates me and what makes me want to come back to Congress in January is that there are issues our constituents care about, and they're not divisive issues. And so thank you all for working on a unifying issue, which is our health, and also the jobs that can be created in this PGX economy because of what we know about a patient's genetic sequencing and how we can make them healthier. So Tom, I'm with you to take this on, and Invitae and the partners here today count on us as people who want to get things done, bring down costs, and extend life. So thank you all again.
Thank you so much, Representative Swalwell. Really appreciate that, and your comments as well, Representative Emmer. I'm Christine Ashcraft. I'm a molecular biologist by training. I've spent 20 years in pharmacogenomics. I currently lead those efforts at Invitae, a leading medical genetics company. I've co-authored multiple publications on the clinical and economic benefits of pharmacogenomics. I firmly believe that precision medicine is patient safety, and that pharmacogenomics is a foundational element. Today, you will have the opportunity to hear from some of the leading experts in pharmacogenomics, who I will introduce before they present. But first, I'm going to provide a high-level overview of pharmacogenomics, including why it has such a significant impact on patient outcomes and healthcare costs, and needs to be more broadly integrated into the healthcare system. Next slide. This is Michael. He died of an overdose because he had a pharmacogenetic variation that impacts response to many medications, for many conditions, for life. In his case, the variation, in combination with his other medications, caused a deadly increase in Prozac levels in his system. I first heard his story 20 years ago, and I have dedicated my career to ending avoidable adverse drug events like Michael's. Pharmacogenomics is an underutilized tool in achieving this mission. Next slide. Put simply, pharmacogenomics helps us move from one size fits all to understanding when genetics would lead to selection of a lower dose, a higher dose, or an alternative medication. Unfortunately, Michael's story is not an uncommon one. 99% of patients have a pharmacogenetic variation that will impact their response to one or more commonly prescribed medications. Although pharmacogenomics is not the only cause, not taking this variability into account is part of the reason we lose a life every 2 minutes in the United States due to non-optimized medications. In 2016, we spent $528 billion on non-optimized medications. To put that in perspective, that is more than we spent on any major disease and more than we spent on the drugs themselves. And the more medications you take, the more likely you are to have a problem. We now have 50 million patients taking 5 or more medications every single day. With the silver tsunami of aging boomers, we expect that to double by 2040. Next slide. Spiraling drug costs are a huge concern, and lowering treatment failures would help. Half of the medications we take are ineffective, ranging from 38% of antidepressants to 3/4 of cancer medications. Next slide. Historically, we have only flagged for binary drug-drug interactions, even though the FDA has stated in drug development guidance for decades that drug-gene interactions should be considered equivalent. The FDA includes pharmacogenetic guidance in over 100 product inserts for medications. Next slide. We've had the technology for many years to do far better. Do you remember when we used to unfold the paper maps in our car to get from point A to point B? Now virtually everyone uses real-time traffic apps that warn of metabolic traffic or warn of traffic jams and reroute. Most medications we take are processed out of our body through enzymes in the liver. Think of these enzymes like highways. We prescribe assuming everybody has 2 lanes of these highways, when genetically, some people have 1 lane, 0 lanes, or 3 or more lanes. We then add traffic, drugs, herbals, over-the-counters, foods like grapefruit juice. We have the technology to detect metabolic traffic jams in real time. And just like your traffic app offers alternates when there's an issue, we can provide real-time alternatives that reduce adverse drug event risk. We need to stop addressing a multi-factor problem with an outdated binary solution. Next slide. Sorry, next slide. We worked with a major US payer on a claims analysis for 100,000 patients, including 20,000 Medicare patients. Patients taking medications known to be impacted by pharmacogenomics cost more. For Medicare, it was most pronounced at $345 more per month. Next slide. We know the costs rise, but what happens when we add pharmacogenomic testing and improved clinical decision support? In patients 65 and older with pharmacogenomic risk, compared to a 4-to-1 matched historic control, we saw 71% fewer emergency room visits, 39% fewer hospitalizations, saving $11.32 per patient prior to the test cost in just 4 months. Next slide. I read a few weeks ago that over half of hospitals were fined by Medicare for readmissions. In a randomized controlled trial of patients at high risk of readmission, pharmacists visited patients in the home in both arms, as medication-related issues are a major cause of readmission. In the arm where pharmacists were provided with pharmacogenomics and improved clinical decision support, there were 52% fewer readmissions, 42% fewer emergency room visits, 85% fewer deaths, saving $43.82 a patient in just 2 months. Next slide. Medications with high evidence impact virtually every specialty. Of particular note is that the same genes impact multiple medications across multiple areas, those same key highways. Most laboratories in the US run multi-gene panels, but they can only report on a single drug gene pair or within a single disease state, even though those same genes impact medications across all of these different specialties for life. This is because the historic path to gain reimbursement is done this way, not because it is what is best for patients. Would you invest in a seatbelt and only have passengers wear it when driving at certain times of the day or on certain roads? Next slide. Plavix or clopidogrel is commonly given to patients to prevent having another heart attack or stroke. The FDA placed a black box warning that patients with certain pharmacogenetic variations are at a greatly increased risk and need an alternative medication. In an analysis of several thousand patients, over 60% had a significant genetic variation beyond the gene tested for Plavix. If only a single gene is ordered and reported, we miss the opportunity to avoid a lot more adverse drug events. Next slide. Opioid dependency and overdoses are constantly in the news. Patients with pharmacogenetic variants are undertreated or overtreated at standard doses, leading to 2 to 3 times higher rates of dependency and death in patients with pharmacogenetic variations. Next slide. We are in the midst of a public health crisis with COVID-19. Depression and anxiety are on the rise, and pharmacogenomics can help. Next slide. These same pharmacogenomic genes, these main highways for drug metabolism, have been shown to improve chances of effectiveness and adherence, reduce medication costs, and reduce length of stay. Next slide. We tax our hospital resources whenever COVID cases surge. We recently collaborated with a major US payer and looked at the length of stay for hospitalized COVID Medicare patients and how that correlated with the number of pharmacogenomic medications and their risk. Next slide. When a patient had a greater than 50% likelihood that pharmacogenomics would impact their care, length of stay increased 13%, and in the 25 to 50% range by 8% in otherwise risk-matched patients. Next slide. Most of the $528 billion spent on non-optimized medications occurs in seniors, who are 400% more likely to have an adverse drug event. Even with the cost of a one-time pharmacogenomic panel that can last a lifetime and improve clinical decision support upgrades, we would only need to reduce that number by 5% to save almost $10 billion a year. At 20%, we would save $50 billion. Next slide. If you remember nothing else I have said, please remember that although pharmacogenomics has value in use cases for drug gene pairs, we need to think about the value based on a lifetime impact in improving medication safety and effectiveness. A reasonably priced panel of pharmacogenomic tests and improved clinical decision support can help us make the safest, most effective medication choices the current evidence allows for the rest of a patient's life. We have the tools today to make the same jump forward we took when we moved from paper maps to real-time traffic apps. Only instead of providing the best route based on traffic jams and lane closures, we can base it on genetics and other factors that impact drug response. It has been 20 years since Michael's avoidable adverse drug events. We can do better together. Thank you. So that's a high-level overview. Please reach out if I can provide any more detail. I know I covered a lot quickly. I now want to introduce you to Michael Polak, who has served as the Chief Executive Officer of the Depression and Bipolar Support Alliance since June of 2018. Michael has more than 20 years experience leading nonprofit organizations. Members of Michael's family have been impacted by depression, bipolar, and other related diagnoses, so he understands on a personal level the positive impact DBSA can have on the lives of people with a mood disorder. Michael?
Thank you, Christine, and hello, everyone. Thanks for the opportunity to share with you the role pharmacogenetics can play in delivering quality mental health care to people living with depression and bipolar. Again, I'm Michael Polak, and I serve as CEO of the Depression and Bipolar Support Alliance, or DBSA. We were founded 35 years ago on the idea that patients, or as we refer to them, peers, supporting other peers is a key component to an individual's health and wellness plan. Today, DBSA supports over 150 chapters around the country, and we have more than 500 support groups that meet on a regular basis. Most have since transitioned to online support during this pandemic. Through our online presence, we provide education and wellness resources to the public. That's all been vetted by our scientific advisory board that's comprised of some of the most respected clinical researchers in the area of mood disorders, depression, and bipolar. Next slide, please. So past data shows that 16 million Americans experienced at least one major depressive episode just in the last year. However, we have seen a dramatic increase since the outbreak of COVID. In April, the CDC began collecting data on the state of America's mental health. In the CDC Mental Health Household Pulse Survey, that data are constantly being updated, and frankly, it's pretty alarming. 26% of Americans now experience symptoms of depression. Compare this to the CDC data from just a year ago, which reported 6.6%. The potential for an increase in deaths by suicide is no less alarming. Again, according to the CDC, death by suicides is now the 10th leading cause of death in the United States. And the pandemic has exacerbated this situation. According to published research from the chair of our scientific advisory board, Dr. Roger McIntyre, the rapid rise in unemployment because of COVID is predicted to increase suicides anywhere from 3.3% to 8.4% annually. Dr. McIntyre has pointed out that these results indicate that suicide prevention in the context of COVID, related to unemployment in particular, is a critical priority and needs to be. Next slide, please. Congressman Swalwell called it a diagnostic odyssey. We call it trial and error. And unfortunately, today's standard of care for depression is a trial and error method of medication selection, with patients often responding to the first treatment only half the time. Extensive studies that were conducted by the National Institute of Mental Health show that failure on just one antidepressant medication increases both chances of second failures and also the rise in risk of suicide. And this idea is reinforced by DBSA's own outreach to our community. In 2018, we surveyed more than 6,400 individuals on the impact of depression and bipolar. Of those 6,400, 2/3 indicated they've experienced up to 10 discrete periods of depression symptoms, or they reported that their symptoms are ongoing and persistent. Further, almost 24% reported the frustration at this trial and error methodology. It's kind of like throwing things against the wall as an approach to psychiatric treatment and medications. Next slide, please. Depression and bipolar is also costing employers an estimated $23 billion annually in lost workdays and related expenses. We heard firsthand from our community in that 2018 project at our externally led patient-focused drug development meeting. An externally led PFDD is parallel to the FDA's program, Patient-Focused Drug Development Initiative. At our meeting, these meetings bring together the FDA staff and medical product developers, pharmaceutical and device industry organizations to hear directly from patients about the unmet need in treating a disease or condition. And attendees shared that the natural life transitions are often delayed or they're simply never attained. Some of them you see on the screen there. Academic performance is hindered, the choice of a profession or of an employer or the type of position someone pursues, possibly the need to take a less demanding job, or staying with a particular employer because of the benefits program, even if it's not the kind of job or career path somebody wants to pursue. Peers have reported impact on their financial stability and in their family relationships. with spouses, other romantic relationships, with their family responsibilities, and with their friendships. Next slide, please. DBSA's core beliefs include recognizing that there are several pathways to treatment. They can include peer support, personal wellness strategies, therapeutic and medical interventions, and all patients have the right to direct their own treatment. Clinicians should be collaborating with patients or peers to provide options when developing personalized treatment plans that target complete wellness and not just symptomatic improvement. We believe all stakeholders share in the goal of fostering innovative therapies that provide peers with the ability to lead the lives they want and that they deserve. Major depressive disorder is a chronic condition that can interfere with and delay natural life events and transitions. Medical product development innovation focusing on whole health is under prioritized currently. And progressive nature of the conditions leads to concerns about ongoing efficacy of the treatment options. Peer desired outcomes go beyond just surviving. People with mood disorders seek the opportunity to thrive. Thank you again for this opportunity. And Christine, I'll turn it back to you.
Thank you so much, Michael. I appreciate your input. I'm going to turn it over now to Russ Altman. Russ Altman is the Kenneth Fong Professor of Bioengineering, Genetics, Medicine, Biomedical Data Science, and Computer Science, and the past chairman of the Bioengineering Department at Stanford University. His research applies computing to problems relevant to medicine, and he is interested in methods for understanding drug action at the molecular, cellular, organism, and population levels. His lab studies how human genetic variation impacts drug response. He co-leads an FDA-supported Center of Excellence in Regulatory Science and Innovation, and is a member of the National Academy of Medicine, past president of the International Society for Computational Biology, and of the American Society for Clinical Pharmacology and Therapeutics. Russ?
Thanks very much, Christine, and hello, good morning, everybody, good afternoon. I'm talking to you today from the perspective of my MD, a little bit more than my PhD research, because after 20 years, like Christine, in this field, I decided it was time to open up a clinic and start using this for the benefit of patients at Stanford Hospital. Next slide, please. So you've heard already that pharmacogenomics and genetics is the study of variation in drug response due to genetic differences. And we really do have this vision of making sure that we can predict when a drug will work, when we need to use that drug, but perhaps at a different dose, what side effects we should be worried about when we use a drug, or should we just use a different drug based on the predicted response. Next slide. So I'm going to tell you a story today, a real story, and it's based on Tylenol number 3. This is a regular old Tylenol, but with some codeine added. And many of you may have had this for a minor procedure. No procedure is minor. A tooth being pulled or a short surgery. And the key thing is that codeine, which is the ingredient in Tylenol number 3, is inactive until the body, in fact, the liver enzymes that Christine was telling you about earlier, until those enzymes, I'm pointing at my liver, transform it into morphine. And morphine does relieve pain. It's a somewhat famous pain reliever. Now, the gene that does that transformation, and I apologize for this crazy name, is called CYP2D6. But the key point for pharmacogenetics is that 7% of people of European descent have small differences in their DNA that leads CYP2D6 to not turn codeine into morphine, and therefore those people have no pain relief. Now imagine going to the dentist and getting your tooth pulled or having a surgical procedure where you're given codeine, the day before, but it doesn't work, and so you're having quite a significant amount of pain. That is not a pleasant experience, and it's something that can be avoided. And I should stress that there are several other pain medications that have the exact same story. So that's your background. That was your Pharmacology 101. Next slide. This is Debbie. Why I have a movie of Debbie on the internet, I'll get to in a second, but she was a patient of mine. And she came to my clinic and we did a pharmacogenomic panel. And she said, Dr. Altman, I have a deviated septum in my nose, and I'm going to have it repaired, but I don't want to do it because I've had 2 other surgeries in my life, and there was no pain relief at all when after my surgery, and it was agonizing. And so in my test of her, I said, you are one of these CYP2D6 unusual metabolizers, and they probably used all these drugs that simply didn't work. I want you to use this other drug for pain relief. And I wrote it in my note. The reason I have a movie of her is she was part of a study at Stanford where we prospectively followed patients through their health journey, interviewing them and even videotaping them. And so we didn't know what was going to happen. But let me tell you the story because it's pretty entertaining. She went to her surgeon and said, well, Dr. Altman tested my DNA and he said I shouldn't use these drugs. And we should instead use this other drug. And my colleague, the surgeon, said, well, I'm not very familiar with that drug. I don't use it very much. I prefer to use these drugs, the ones that wouldn't work. He didn't. And she said, well, if you're not going to use the drug that Dr. Altman recommended, I'm not having the surgery. And so my surgical colleague said, well, I guess we can try that drug. And they went ahead with the surgery. So this is a movie that's available with Debbie's full consent, where she was coming out of her anesthesia and she was reporting freshly, and you can watch this, there's a URL at the top. She's reporting freshly how she feels. And the bottom line is she's saying, oh my goodness, I'm feeling good because this pain relief, whatever they're giving me, the drug that we recommended, is working very well. So this is the kind of story you heard about, the young child that died from Christine, and those are rare, terrible events, but there are these common everyday events as well where pharmacogenomics can help. Next slide, please. So this is I know that you can't see the details of this, but this is the dashboard that I use in my clinic after I get the tests. And a very important principle and an area of active research and also delivery is making sure that we provide physicians with the clinical decision support that they need to make these decisions in the clinic, in seconds, because many of our visits are only 10 or 15 minutes long. And so I use this tool. Next slide, please. And this is just the screen that would have shown me that Debbie was not going to do well on codeine, and this decision support tool also gave me some other options that I could recommend, and that's what I used when I told her to try a different drug. Next slide. So where did we get this information? So there's been research for 20 years in this area or more, really longer. But what we needed was we needed a way to summarize for practicing physicians how they could use genetics in their practice. And so we and others formed a consortium. It's called CPIC, CPIC, and you can see the first 4 words of that article, Clinical Pharmacogenetics Implementation Consortium. And this is a broad group of industry, government, and academic scientists who get together and write guidelines about how to use genetic information to optimize the use of drugs. And this is the one for codeine that all of my decision-making for Debbie was based on. So CPIC does this for drug after drug after drug. It is funded by the National Institutes of Health, and it provides this incredible service of taking all of the published scientific literature and boiling it down for practicing physicians. Here's what you can do in your practice. Next slide. So I just want to say that even that one gene, CYP2D6, affects hundreds of drugs, some of the most common of which I've highlighted here with their common names that you might recognize. Prozac, Paxil are antidepressants. We just heard Michael talk about that field. You see on the right side some pain medications. Tamoxifen is very important in breast cancer, and it just goes on and on and on, as Christine said. Next slide. So we were all extremely happy to see that there is move among payers. So one of the challenges, I should say, is that when I started my clinic 3 years ago, it was a cash-only clinic because we couldn't get reimbursement routinely for these patients. So we were all extremely excited when one payer last August announced that they would cover pharmacogenomics in certain settings, in fact, in the setting of depression. And this is an important step because we believe that now other payers, including CMS, the government payer, will start getting serious about covering this so that it doesn't become just a service for those who have the resources to pay, but it becomes a service that's available to everybody. Next slide. when United Health, which is the company that decided to cover for depression, when they released their statement about why and how they were going to cover it, we were very happy to see that they had read the scientific literature and they had read the CPIC guidelines. Next slide, please. This is more than you need to see, but you have to take my word for it that most of the evidence that they referred to in this table, much of it was the CPIC guidelines. So we were very happy to see this because it means that this effort to boil things down for physicians was also being noticed by other constituencies who could use the information for major policy decisions. Next slide. The FDA has been watching this. They don't like labs that are going direct to consumer. And so there is some debate and discussion about the appropriate role of FDA oversight of pharmacogenetics. And I just showed this slide because it's an active area and it's something that should be watched. And because it impacts the ability of me as a physician to get access to these tests and to use them for my patient's benefit. Next slide. So I think that's all I wanted to say today, and I want to thank my coworkers, both on the clinical side and the research side, and it's back to you, Christine.
Thank you so much, Russ. Always a pleasure. Dr. Deepak Vora is coming up next. He's an associate professor at Duke University School of Medicine. His research focuses on the use of genomic biomarkers to individualize drug therapy with the goal of improving medication efficacy and toxicity. As the director of the VA Phaser program, he leads the VA's clinical nationwide implementation of preemptive pharmacogenetic testing. Dr. Vora?
Thanks, Christine, for that introduction, and thank you all for participating in this event. As Christine mentioned, I'm a cardiologist as well as a physician scientist. And most of my research has focused on an area of medications called statin medications. And so in the next few slides, I'll be telling you a little bit more about how pharmacogenomics can be used in this important area of preventing cardiovascular disease. Next slide. So just to level set briefly, in case you don't know, cardiovascular disease is if not the leading cause of death in the United States. Statin medications, these go by the names of medications like Lipitor, Zocor, and Crestor, are medications that have been around for decades. They are medications that can powerfully lower not only cholesterol, but dramatically reduce the risk of cardiovascular disease. And because of the research that's been done around statin medications and their proven efficacy, up to 1 in 3 Americans or US adults can benefit from being on these statin medications. And despite their proven benefit, we know that up to 1 out of 2 adults who should be taking these medicines is not taking them as directed. Next slide. And so when we think about why patients and providers are not prescribing or taking statin medications as well or as optimally as they should, we've learned a lot. And although statins have a rich data and research around them, and many of them are generic and often offered for free, we still see that there's significant barriers to uptake of these medicines. One of the most common reasons that patients and providers cite for not prescribing or taking statin medications appropriately is a concern for side effects. And so 1 out of 10 patients who take statin medications often report side effects in the form of musculoskeletal aches and pains. And if you ask patients who have stopped taking statin medications, what was the most common reason they stopped taking it, the number 1 reason is that they cite is due to side effects. There's also a lack of perceived benefit of statin medications. And although we have all this great research suggesting that statin medications are demonstrating that statin medications are beneficial, there's a perception often by patients and sometimes providers that the medicines are not effective and are not and shouldn't be prescribed. There's always also a knowledge gap that needs to be overcome through things like education And the cumulative effect of these things are often to create barriers to the optimal use of statin medication. Next slide. So what have we learned over the last decade of research around statin medications, and particularly around the pharmacogenomics of statin medications? And what we've learned is that through pharmacogenomic profiling, we can start to target subsets of patients who are more likely to benefit from statin medication. We've also learned that there are subsets of individuals who are more likely to get side effects from statin medication. And so instead of randomly prescribing a certain specific type or dose of statin medication, we now can peer into a patient's genome and individualize not only the dose, but also the type of statin medication a patient should receive in order to reduce their risk of side effects. And we think that the cumulative effects of these advances in pharmacogenomics for statins will make it easier for not only patients to accept a statin prescription, but providers to prescribe it appropriately, and then for patients to adhere to that medication and receive the cardiovascular benefits from it. Next slide. And so I've spent the last few minutes telling you about one medication and one story, but as you've heard before already, that statins are really just one of hundreds of medicines that have some form of genomic interaction in terms of their risk of side effects or how well the drugs work for these patients. And pharmacogenomics is not something that's off in the future. It's already starting. There are many healthcare institutions and healthcare systems that are already offering pharmacogenomic testing currently. And we expect this practice to expand. In terms of where I see the future of research in this space, I think we have enough information now to know that pharmacogenomic testing can be beneficial, but I think the future is now about measuring how much value there is. And when I talk about value, I talk about value from the perspective of the patient, and not only in terms of their quantity, but the quality of the life that they spend. We talk about value in the terms of the provider. How can pharmacogenomics make it easier for providers to take care of their patients and prevent and treat disease? We talk about value from the standpoint of health systems. Can we prevent or avoid hospitalizations, ER admissions, and shift care to more non-acute outpatient settings? And finally, is there value to the payers? And ultimately, can we reduce costs? And how much can we reduce costs through this type of innovative testing? And so, with that, I want to thank you for the opportunity for talking to you all. I'll hand the ball back to you, Christine, and look forward to any questions or comments from our participants.
Yeah, thank you so much, and really appreciate that, Dr. Vora. We are now opening it up to questions from the audience. I actually see one here that I'd like to talk to all of our panelists about, because I think it's the biggest question. And we can start, since you just spoke with you, Deepak. What are the current biggest obstacles in making pharmacogenomics standard of care more broadly, in your opinion?
There are lots of barriers, I agree. I would say access and coverage are one of the biggest obstacles. In order to allow providers to be able to order this test for their patients and not have them to cover the cost of that test out of their pocket, I think improving access and coverage would help. And there are many others, but that's the one that comes to mind at first.
Okay. And Michael, what do you think the largest obstacle is in terms of the patient perspective?
Well, for one, many patients just don't have enough knowledge or information. And so one of our objectives is to educate people living with mental health conditions. How do you talk to your doctor about pharmacogenetics? What does the patient need to understand first and foremost, so that he or she's really equipped to have those conversations and to advocate for themselves and to ensure that their doctors are indeed listening to their needs and also getting educated themselves. We try to educate the patient on cost issues, but also privacy issues. And we provide this information on our website, dvsalliance.org, but we also provide links to other organizations and entities that are also trying to educate patients, family members, caregivers, just so that we're all better informed going forward.
Excellent. Thank you, Michael. Russ?
Yes, so we've talked about payment issues, and we've also talked about evidence. And in both those areas, we're seeing improvements, and I think there's a ball rolling there. Another issue, though, and as a practitioner, is inserting this into the workflow of physicians so that they can use it and they can use it effectively and quickly. There's been studies that show that physicians want to use this information, but they don't feel prepared and they don't feel that they have the tools in their electronic medical record system to support them. So that becomes a priority too, engineering those systems so that physician workflow is smooth and they can do this without excessive demands on their time.
Excellent, thank you. So we've heard, reimbursement, increasing awareness and education, investing in clinical decision support tool. I think one of the other things is really making sure that we're enabling pharmacists to act at the top of their scope of practice. So if I had a heart attack, I would be referred to a cardiologist because cardiologists are specialists in that area. If I am taking a lot of medications or one of my loved ones is, I would want those to be referred to a pharmacist for review. A pharmacist goes to school as long as a medical doctor to study pharmacology and how medications work. And right now they're not federally recognized as healthcare providers, which are creating barriers to enabling them to practice at the top of their practice and really help us deal with the adverse drug event epidemic. I would say those other barriers are high, but that is also a barrier to improving medication management, including the incorporation of pharmacogenomics in my mind. So we have another question here. It's Black Men's Health Week. Are there studies specific to the African American community? And Russ, I'm going to call you out here because I know you've been doing a lot of work in this arena for a very long time. Can you speak to that?
Yeah, this is a great question, and I have 3 points. The first point is there is no doubt that most of our genetic discovery in pharmacogenetics and really all of genetics has been done on European populations, European descent. And so everyone in genetics, I think, has recognized that we must address that by increasing the number of studies of underrepresented groups, including Black African Americans who have not been represented in studies. That's the first point. The second point is that we know that it matters because there have been studies that show that certain drugs might, on average, work better or worse in the Black population. And this is because, I don't want to go into too much technical detail, but most variations that we see in the genome are present in all populations, but their frequencies are different. So imagine the story that I told about the codeine. The frequencies of some of those codeine important genes and their variations would be different in different populations, which would make certain drugs more or less likely to work. So we know it matters. So the first point is it hasn't been studied enough. The second point is we know it matters. And the third point is there is light at the end of this tunnel because of these large cohort groups that have been brought together. We have the All of Us program in the United States where the NIH is leading a 1 million person group that we're following prospectively to study their health. It includes an emphasis on Black populations as well as other underrepresented minorities. In addition, the VA, the United States Veterans Administration, has a program in pharmacogenetics and genetics more generally that specifically includes many, many vets who are African Americans. So I think we've recognized the problem and we're on the way towards improving that imbalance in knowledge.
Excellent. Thank you so much. So we are seeing everyone's comments and questions on policies. We do want you to know that we have developed policy, as Congressman Emmer and Stallwell mentioned, and we'll follow up with you after the briefing. We want to work together and need your input. One of the questions here, how do you determine how much evidence of a link between a drug and a gene and an effect is sufficient to constitute a medically actionable information, and who determines that? I think I will pass it over maybe to Russ afterwards, but Deepak, do you want to comment on that as well?
Yeah, it's a really insightful question and a really important one. I think I would say the answer is that it depends and I don't mean to be coy there. I think for each drug gene pair and each indication for each drug, it's gonna come up with a series of different levels of evidence. So maybe I'll paint an extreme example. So if there's a discovery that, for example, only certain people who carry a genetic variant benefit from a medicine, and they're the only ones that benefit from that medicine, you may say that the level of evidence that's required is a randomized clinical trial, a prospective clinical trial showing that in people who carry this variant who are randomly given a drug or the alternative, whether they benefit. You know, because you're often making a decision about giving a new drug or withholding an existing drug to that patient population. And so there, the level of evidence has to be really high to use that information. On the other end of the spectrum, you may say, I have 5 different drugs that can be used for this one indication. They're all the same cost, they're all about the same efficacy, and this genetic marker can help me pick which of those 5, essentially reprioritize which one needs to be given and which one shouldn't be given. There, I would say, I think that the level of evidence doesn't have to be a high level, as high as a randomized clinical trial. We can accept perhaps lower levels of evidence based on pharmacology, retrospective data. I'm not saying that it shouldn't be an evidence-based practice. I'm just saying that the level of evidence should be different. So I think at the end of the day, it's the clinicians that prescribe that medicine and the patients that receive it need to form a consensus about what the level of evidence needs to be for that drug gene pair, and then and once that bar has been set, then we can examine what level of evidence exists. If the threshold hasn't been crossed, then a research study should be done. If that evidence threshold has been crossed, then we should advocate for using the test. So we get this question a lot about what is the right level of evidence, and I think it does depend on the decision that you're trying to make and the condition that you're trying to treat, and it needs to be tailored to each drug gene interaction that you're looking at.
Russ, do you have anything that you'd like to add to that?
Yeah, I agree with everything that Deepak just said. I'll just say when I set up my practice, I used the CPIC guidelines as my bar. Things that appeared in the CPIC guidelines, I included in my practice. The other stuff, which was interesting and intriguing, but had not yet had a group of colleagues create a guideline, I just kept an eye on it, but I didn't use it in my practice. And when I was choosing vendors, I want my vendors, my pharmacogenomic testers that I pay to get the results, I want them to be as CPIC compliant as possible. But that's a heuristic, and really the deeper issue is exactly as Deepak just described.
Excellent, excellent, thank you. I will just say that I happen to be on the steering committee for STRIPE, which is a collaborative community working with the FDA on aligning industry standards and guidelines in pharmacogenomics. So if anyone is interested that is not currently involved in that effort, please feel free to reach out. So evolving, but the CPIC is definitely, I would say, an industry standard that most people turn to. Michael, I have a question for you. Given the impact on quality of life, suicidality, and loss of productivity for patients with depression and bipolar disorder, why is it a trial and error system for antidepressant medication? Why is that still the norm? What is stopping psychiatrists and physicians from using this technology to improve that process and improve patients' health sooner and better?
Yeah, that's a great question, and I'll answer it a couple ways. One is there really hasn't been much innovation at all in terms of new treatments for people living with depression and other mental health conditions. And in part, the regulatory process needs to be much more innovative. It's part of why one of our priorities has been to really try to transform the definition of wellness and what regulators require of organizations that are trying to come up with better treatments, more innovative treatments. The regulatory process needs to be expanded and improved. The other is, frankly, there's still a lot of stigma out there. getting more people who live with depression and other mental health conditions the opportunity to share their experience. We throw around a lot of numbers, but at the end of the day, this is about people and people's lives and their livelihoods and their families. Giving more voice to what these experiences are like for individuals is can't be understated. There are lots of venues around the country now. Most of them are virtual, whether it's sessions like this, educating lawmakers and their staff, or whether it's conferences educating the medical community, the insurance industry. Often the patient voice is missing. The individual experiences that allow individuals with mood disorders and other mental health conditions to share their experience, and to have that experience really be at the center of the conversation is still lacking. So those are a couple of reasons, Christine, that I would point to.
Excellent, thank you. I know we're nearing the end of our time together. I will have a few closing comments in a moment, but I just want to give the opportunity to each of our panelists to state anything in closing that they feel is important as a takeaway to our audience today that they may not have mentioned already. Russ, do you have anything else you would like to add?
I did not know that this caucus existed, and it made my month to find out that it did. So thank you for your work.
Awesome, thank you. Deepak?
Yeah, I want to echo Russ's sentiment. I think, in general, although we know we have a lot of great data that this type of innovation can help patients, I think more evidence is always better. And if coverage decisions and policy decisions can be aligned so that we generate evidence in addition to improving access to pharmacogenomics, I think we'll be in a better place.
Excellent. And Michael, anything more to add?
I would just add that while I've spoken on mental health, and we've talked about other diseases like heart disease or diabetes and others, none of us, people that have these conditions often have more than one condition. So we have to remember that opportunities like pharmacogenetics needs to be considered in kind of the context of a person's whole health and their entire being, and really the comorbidity that often exists with people that we kind of highlight or showcase when we talk about having one particular diagnosis.
Excellent.
Christine,
well,
one other point is I
yes.
do notice questions that we didn't get to, some of which were directed. And so I don't want to speak for my other panelists, but I would be happy to receive private emails and I would try to answer them.
I would agree with that statement as well. We would be more than happy to answer additional questions. I'm sorry that we weren't able to get to all of them. Really appreciate everyone from Congress and the community for attending today. A special thanks to Representative Swalwell and Emmer and our panelists, Russ Altman, Deepak Vora, and Michael Polak. I just want to say in the time allotted for us to speak today, we spent $60 million on non-optimized medications and 30 people lost their lives. We already have an adverse drug event epidemic, and it will get worse with aging baby boomers and increasing numbers of drugs prescribed. It's been 20 years since Michael died of an avoidable adverse drug event, and it is unlikely today that his physician would have had the pharmacogenomic information and improved clinical decision support to do better. We can do better, we must do better, and we look forward to hearing from you if you would like to help us make the changes needed to incorporate pharmacogenomics and improved clinical decision support more broadly into our healthcare system. Thank you so much.